Good afternoon, everybody, and thank you for joining us for our first town hall of 2022. We're talking Trikafta today. It is my pleasure to introduce Dr. Susanna McColley from Lurie Children's Hospital and Dr. Manu Jain from Northwestern Medicine, who will be sharing a comprehensive update on our newest modulator, Trikafta. And without further ado, I'll turn it over to Dr. McColley to get us started.
Hi, everyone. Thanks so much for coming today. I see lots of friends in the audience, and I'm delighted to be here to share the stage with my good friend, Dr. Manu Jain. I'm going to kick us off, and then I will hand it over to him, and then I will do the wrap up. So you all know about Trikafta, and I have a couple of disclosures because I have worked with Vertex pretty extensively on these studies, and they pay Lurie Children's Hospital for some of my time, which they should. So some of you may be familiar with this. This is actually a slide. You can see that there's like a head at the bottom because I took this at the North American Cystic Fibrosis Conference in 2019. So these are three guys drinking whiskey. They are esteemed academic researchers, and they're drinking whiskey in the morning. And the reason for that is that they put together a long puzzle with a lot of hard work and collaboration, which was the discovery of the cystic fibrosis transmembrane regulator gene. And this was the cover of Science magazine in 1989. And I remember this day vividly because I was a pulmonary fellow at Johns Hopkins, and the news media was blurting out that now we're going to have a cure. And we had parents calling and saying, can I get the cure at my next appointment? And of course, we knew that after discovery, there was a lot more research to be done, but it did give hope, and it really started the era of intensive research into cystic fibrosis, which was incredibly important, for development of drugs that aren't quite as effective, but have made a big difference, like rhDNase, which is pulmocine. So that's what this is, but this is the guy who was this little boy who spoke at the North American Cystic Fibrosis Conference in 2009. And this cover came out a little bit before that and was just talking about how important it was that CF was discovered because the gene techniques used were a huge benefit to science. But there was also a comment from one of the guys drinking whiskey that they thought that CF had done more for science than science had done for CF. But this was 2009, and so that was going to change in just a couple of years with the approval of Kalydeco. And then, of course, this is the 2019 North American Conference. Who knew how many we would not be at in person after that? And this is the tall guy in the picture. So this is Francis Collins, who just retired from being the director of the National Institutes of Health. And of course, he was celebrating Trikafta, a highly effective oral small molecule therapy for people who have one or two copies of the F508 del gene, which is about 88% of people with CF in the United States. And I'm just going to note that this is precision medicine. It's based on your genetic composition. And when President Obama introduced the Precision Medicine Initiative, which is now called the All of Us program, he talked about this guy, Bill, who was alive thanks to Kalydeco. And Bill had a mutation that was responsive to that. So this was a big celebration, and we continue to celebrate the success with modulator drugs. This is kind of a very sad picture to look at, but I do just want to emphasize that even before Trikafta, we made a lot of progress in CF care. So before CF centers, children presented with malnutrition, vitamin deficiency, and they got lung disease very early, and it was actually rare to survive to adulthood. This is from a journal article in 1949. I'm only 12 years older than this journal article, so we've made a lot of progress, and we will continue to make progress until this is done. And with that note, I would like to point out that there are now more adults with CF than children with CF in the United States. This is thanks to research care programs and people like Dr. Manu Jain, and he is going to take it away from here.
Thank you, Dr. McColley. It's a nice segue into talking about Trikafta. Next slide. So my goal today is to walk you through some of the research studies that led to the approval of Trikafta, and then talk about some of the real-world effects that we've seen with this medication, which is actually a combination of 3 different medications: elexacaftor, tezacaftor, which we also refer to as correctors, and ivacaftor, which is a potentiator. And so it really is 3 drugs working together to rescue CFTR function, and it's applicable to about 90% of all CF patients who are the right age. Now, I'll talk a little bit about, and Dr. McColley will talk about the studies as they're going into a younger age group. But for right now, this Trikafta is applicable for patients 6 and above. So with that as a prelude, I'll just show you the initial studies that led to approval. And the first group of patients who were approved were patients who had F508del homozygous mutations and patients who had one F508del and a second mutation, which we call minimal function, meaning that there was almost no CFTR function with that second mutation. And what I'm showing you on the left is the results of patients who had the minimal function genotype. And you can see in that blue line, there was about a 14% improvement in FEV1, which is a remarkable improvement, much better than we've seen with any modulator prior. And the improvement was seen within a couple of weeks, and then it persisted out to 24 weeks, which was the duration of the randomized study. And then if you look at patients who were homozygous for F508del on the graph on the right, you can see also that they had an improvement that was substantial as well, about 10% or so. Now, one thing to remember about this group is that the comparison group in the red line were already on a modulator called Symdeko or tezacaftor and ivacaftor. So they had already gotten an improvement because of that modulator, and the 10% we saw was on top of already having been on tezacaftor and ivacaftor. And as you know, sweat chloride is used to make the diagnosis of CF. Can you go back for a second? One of the things we look for is to see how effective these modulators are in terms of decreasing your sweat chloride as a measure of how well it's rescuing CFTR function. And in each of these groups of patients, there was a 40 milliequivalent fall in sweat chloride. We think about sweat chloride above 60 as making the diagnosis of CF. And most of these folks, their mean sweat chloride prior to starting study drug was 100. So if you subtract 40 from that, you get actually below, or right at the level or below the diagnostic threshold of CF, which is a remarkable finding. Next slide. Now, a second group of patients that was studied and the results came out last year were patients who we had a mutation that was what we call residual function. What that means is that the mutation that they had has some CFTR function remaining. These patients tend to do a little bit better than patients who have more severe mutations as a group. And these patients who were in this particular study who were already on what we consider a very effective modulator, either Kalydeco, ivacaftor, or Teziva, which is Symdeko. And the comparison was, can you get added benefit by switching to Trikafta if you're already on Kalydeco or Symdeko? And what you can see is that the answer is yes. On the left, I show you the change in the lung function. There was about a 4.5% added improvement on your FEV1. Now, harken back to remember that if the initial ivacaftor Kalydeco study showed that you had about a 9–10% improvement in your pulmonary function when you started Kalydeco, and this was on top of that. So again, an additive effect of Trikafta. And when you look at sweat chloride, you can see there was about a 25 milliequivalent fall in sweat chloride, which was on top of what they'd already seen with Kalydeco or Symdeko. So again, you get this added benefit by using this triple combination. Next slide. Now, one of the things we always want to know is, are the results we see in a clinical trial, can you actually see it in the real world? Because there are some, subtle differences between people who may be in a trial versus people who may not be in a trial and just get it as part of their usual treatment course. So it's always good to be able to replicate what you see in a trial, in a study. And the CF Foundation has embarked on a study called the PROMISE study, which is enrolling people who are starting Trikafta as part of their usual treatment regimen. Now, that study has been going on for about 2 years now, so we're starting to see some results back from this particular study. And Northwestern and Lurie are both participating in this study. And what I'm showing you is information from this study on terms of what's happened to pulmonary function. And you can see that there's 3 sort of types of people who are enrolled in this study. People who were on ivacaftor or Kalydeco, which is in the red, and the yellow or orange are people who were on either Symdeko or Cambi, and then people who were not on a modulator prior to starting Trikafta. And as you can see, each of these groups of patients had a statistical and clinical improvement, which was significant in terms of the FEV1. You can see that it happened within about 4 weeks, and it's persisted out to about 6 months or so. Again, very, very important to replicate what you see in a clinical trial in a real world study. Next slide. And one of the questions that comes out of these kinds of drugs is like, what else do we see besides improvement in lung function? And one of the things I just want to highlight, this PROMISE study is going to look at many, many different things, including your sinus symptoms, your GI symptoms, and your infection, effects on infection. And what I'm showing you here is information about what happens to your sputum cultures. And so what they did was they collected sputum prior to starting Trikafta, and then subsequently after at various visits. And what I want to show you is that if you look at the middle panel, which is Pseudomonas aeruginosa, which is the most important bacteria for our patients, you can see that many patients had a fall in their in the amount of Pseudomonas that was in their airways. We can see the mean effects in that red line. Can you just hit it one more time, David? You can see they started out at about 10 to the 6th colony forming units. It's a way to quantify how much bacteria is there. And about 1 month after, go ahead, you saw there was about a little over 100-fold decrease in the amount of bacteria. It was still there, but it was there at a much lower level. And then if you keep going, you can see that a few patients, a small number, were actually able to get to 0. Now, this did not happen in very many patients, but a few patients were able to get to 0. So this suggests that we have effects on infection, but it may be difficult to get to a point where you get completely free of Pseudomonas. Now, remember, these are patients who are a little bit older in terms of who participated. Next slide. So this is a very this is a graph showing what's happened with modulator use over the last 8 years or so. And I just want to make the point that we're in era of Trikafta now. In the green, you can see that beginning in 2014, obviously there was nobody on Trikafta, and it was Trikafta was approved in 2019, and you can see it's been very rapidly implemented in our CF population, going from no patients in 2018, a little under 6,000 in 2019, up to almost 15,000 patients by 2020. And we'll see where we are in 2021. I expect this number to be even higher. And as you can see, as Trikafta use has increased, use of Orkambi, Symdeko, and Kalydeco has decreased as people switch over. Next slide. So one of the other things that we are also beginning to see is the effect on our population as a whole by using Trikafta. What I'm showing you here is the effect of Trikafta on pulmonary function in the whole registry, which encompasses, tens of thousands of patients. And what you're seeing here in each line is a different time frame with respect to what their quintiles of age groups in terms of when patients are being looked at. And what I want you to look at is that regardless of age, by starting Trikafta, you see for the first time that we actually are seeing an increase in our population in our FEV1. This is the first time we've seen this going back to 30, 40 years since the registry has been looking at data like this. This is very heartening to see the effect of Trikafta on our population as a whole. And it'll be interesting to keep an eye on this as Trikafta affects going forward. Next slide. Now, what else have we seen with the effects of Trikafta? What I'm showing you here is registry data with respect to pulmonary exacerbation requiring intravenous antibiotics. If you could just highlight the next one, Peter, David, yeah. So look at what's happened between 2019 and 2020, regardless of the age group, where you're talking about the very young patients, 12 to 17-year-olds or adult patients over the age of 18. Now, a lot happened between 2019 and 2020 with respect to COVID and socially distancing and masking. So I can't attribute all of this to Trikafta, but what you can see here is a tremendous decrease in the number of pulmonary exacerbations as a whole in our community. And this is something we'll have to keep following, but I expect that we're going to have fewer pulmonary exacerbations in the subsequent years as well, which is obviously an important output, important effect of Trikafta. We keep our patients out of the hospital and not needing antibiotics as frequently. Next slide. So what about the long term? Well, Trikafta has been approved for a little over 2 years, so we don't have a really long term to be able to look at this. But we can look at the example of ivacaftor or Kalydeco. This was a study published a few years ago in which Greg Sawicki in Boston looked at patients who had been treated with Kalydeco and compared it to people who had not been on Kalydeco. Remember, Kalydeco was approved in 2012, so we have a longer time frame to be able to look at this. And what he was able to show was that that people who were treated with a highly effective modulator such as Kalydeco, we reduced how quickly they lost lung function by about half. And this was comparing to people who were not on Kalydeco. So this is something that we're going to follow over the next few years to see if Trikafta has similar kinds of effects on reducing the rate of lung function loss. But I suspect that we're going to be able to see this in the next few years as well. Next slide. And then the other thing that that's also been looked at is do we reduce the need of lung transplantation? Do we reduce the risk of death in our patients by using these modulators? And again, this is Trikafta data. This is Kalydeco data, and this looked at 2 different registries, one from the UK and one from the US. And both of those registries, the effect of Kalydeco was that we reduced the risk of dying with CF tremendously, as we did the need for lung transplantation. And so I suspect that we're going to see this with Trikafta as time passes as well. And actually, we have some data suggesting that we're already seeing it. This is the number of patients in our registry who needed a lung transplant going back about almost 20 years or so, back to 1993. In the blue, you see the number of adult patients getting a lung transplant, and in the green, you see the number of pediatric patients who needed a lung transplant. And if you look at 2020, you can see the number of lung transplants done that year for CF patients fell remarkably comparing 2019 to 2020. In the few years prior to 2020, it was pretty stable. So we see this effect of Trikafta and perhaps in the effect of the pandemic as well, fewer exacerbations and such, but clearly a big fall in the number of people needing lung transplants. Next slide. What about survival? This is information that looks at median predicted survival And what this is a reflection of how healthy our patients are in the registry. This takes that information and projects out to what the median predicted survival would be for the group in that registry for that given year. What I want you to look at the difference between 2015 and 19, that cohort, and the cohort between 2016 and 20. And if you circle that, the two groups there, you can see there was a big jump between 2019 and 2020 with respect to median predicted survival. What this tells us is that that group in that registry started Trikafta and had a big jump in their FEV1 such that their predicted survival has now improved tremendously. It's almost 50 years of age now based on this data. And we'll see what happens in the 2021 data. And then if you look at the kind of the flip side of that and look at mortality in the registry, in other words, how many patients in the registry, keep going, David, I think we want to go to the next slide. So if you look at mortality, which is the number of people who unfortunately died in a given year who were in the registry, you can see that the difference between 2019 and 2020 on the right, if you circle that, David, there was a big drop off in the number of patients who died in the registry in 2020 compared to 2019. For the first time in nearly 30 years, we have less than 1%. The percentage is under 1% of people in the registry who died in that given year. So this is also, I think, reflects the effect of Trikafta in terms of benefits, in terms of mortality benefits in our registry. Now, so Dr. McColley had indicated earlier that for the first time a few years ago, we have more adults with CF than children with CF. What I'm showing you now is a projection of what we expect to happen over the next 20 years or so in terms of the distribution of CF patients with respect to age. And what you can see there is I've broken it down into 4 different age groups. The yellow is patients 50 and above. In the green are patients 18 to less than 50. 6 to 17 in the light blue, and then under 6 in the dark blue. And what you can see is that the pediatric group is going to tend relatively stable over that period of time. But look at the tremendous growth we're projecting for the number of adults we're going to have in our registry. The number of people who are going to be 50 and older is going to grow 2 to 3 fold, as is a patient between ages of 18 to less than 50. And this, I think, reflects what we project to happen with Trikafta. So we're going to have an older population of patients that we will be seeing in our clinics, especially the adult side. Next slide. Now we wanted to also look at a couple other aspects of the Trikafta effect. What I'm showing you here is the number of pregnancies that were reported in the registry on an annual basis. And as you can see, there's been this tremendous increase in the number of pregnancies that our CF patients have been able to achieve. Went from 316 to over 600 and 500, almost a doubling over that period of time from 1 year to the next year. And this suggests that Trikafta also affects the ability of women to get pregnant. And this kind of makes sense if you think about that if Trikafta improves your overall health and sense of well-being, that CF women will have less anovulatory cycles. There may be effects on the mucus, the cervical mucus of CF women, since they're able to conceive more easily. There may be a change in how people perceive having a child as well. So it's hard to tease out exactly what the reason is, but clearly, since Trikafta was approved, there's been a big jump in the number of CF women achieving pregnancy. And then I just want to show you effects on, this was a very nice paper looking at the effects on the sinuses. And on the left, you see a patient who is not on Trikafta. You can see in the red that and what I'm showing you is a CAT scan of the sinuses. And where the red is normally should be black, indicating you have air in your sinuses. You can see it's completely blocked. And this is something we see very often with our CF patients. And then after starting Trikafta, you can see that you can actually see where there was red, there's black, and that indicates there's air in the sinuses, which is a normal situation, and the thickening around the sinuses was tremendously decreased. And this is consistent with reports that I see and my colleagues see with respect to patients improving their sinus symptoms. Now, this doesn't happen to everybody, but a lot of patients do improve their sinus symptoms in addition to everything else that we see. So finally, in summary, before I turn it over to Dr. McColley to finish, this triple CFTR modulator Trikafta has unprecedented efficacy. Now, that being said, 10% of our patients, people with CF, still are not have the ability to take a modulator, so there's still a need to develop new therapies for those patients. Even patients on modulators is still not a cure. They may have adverse events. Their effects may be not as profound as other people, and so they still need additional therapies and things in development, which I won't get into too much detail today, but mRNA replacement therapies are being developed. Gene replacement therapies are also being developed. And these are sort of earlier in their development phase, but these are moving forward. We do have other strategies that look at non-CFTR based treatments, looking at alternative chloride channels, non-selective anion channels, which would replace CFTR function. Sodium channel inhibition is still being looked at and developed. So there's a lot of work ongoing to even go beyond what we've been able to achieve with Trikafta. Thank you, and I'll turn it over to Dr. McColley to take us home.
And move on to kids. All right, this up in a good view for everyone. So, when we get these great new treatments for adults, there's always a wait for kids, and there are good reasons for that I will that I will address shortly. But this looks similar to a slide that Dr. Jain showed you, but this really looks at the health of kids with cystic fibrosis before Trikafta, and this is lung function. And as most of you know, we can't really regularly measure lung function in kids who are under 6. So these are birth cohort lines. So these are kids born 1991 to 1995. So they're adults now. I have a kid in that age group. And so at age 6, kids were then starting with pulmonary function about 90% predicted. And remember that the normal range for anyone is 80 to 120% predicted, and average normal is 100% predicted. And then back starting in 2011, look at the improvement in lung function. And because I study newborn screening, I would like to say this is due to newborn screening, which was nationwide by late 2009. But actually it was going up well before then, and that really has to do with just better care at the time of diagnosis and in early childhood. So we've made a lot of progress, and this these data are from before Trikafta was approved for 6 to 11-year-olds, and then so 2019 registry data, or I'm sorry, 2020, and then in terms of nutrition, very similar pattern. Here it's different because kids come in all shapes and sizes, and the normal range is the 3rd to the 97th percentile. Average normal is the 50th percentile, and that's a goal for body mass index for kids over 2 and all the way through adulthood. I'm sorry, all the way to 20, and then they have their own rules. Dr. Jain can tell you about that if you're curious. But so we're seeing kids at age 2 closer to that. By age 3, we're achieving the average normal in kids with CF, and we see it in our patient populations and their health. So now I'm going to talk about what it takes to extend drugs to children. And this varies actually by country. So I'm going to stick to the United States. And so in the US, medicines for rare diseases that are efficacious, which means in clinical trials they work for adults, have special regulations for approval for children. And these have to do with limiting the risk and also being sure that we don't put kids at increased risk by withholding a drug that might work for them while we're doing an experiment. And so these are called label extension studies. And in the United States, they really focus on safety and tolerability. Safety means we don't see big issues that can cause life-threatening complications or make people worse instead of better. Whereas tolerability more has to do with mild symptoms. And in extension trials of younger kids, we do yuck testing because we're doing liquids and powders and things like that. We do need to do what are called pharmacokinetic studies because there's a really sophisticated methodology to model what the drug dose should be in children based on what is needed to get the right blood level in adults. But it's not 100% predictable. So we have to make sure that the right level of drug is in the bloodstream. And that means a lot of blood draws for our clinical trial participants. But again, no randomization to placebo. So all the kids get the medicine. We do look at weight, sweat chloride, pancreatic function, and in kids who were old enough to do any kind of pulmonary function test, we do those. The last thing is that fewer kids are enrolled in these extension trials. And that has to do with wanting to be able to get the data as quickly as possible and to only subject kids to extra blood draws and procedures as much as necessary. And there may be some people out there who were hoping that their child would get into a clinical trial and there was not space for them. So I just want you to know that the purpose is really to bring it to market as quickly as possible. We do long-term safety studies actually in all of these trials to make sure that the drug continues to be safe and to continue to work for them. And so for the 6 to 11 study, for example, of Trikafta, we are still doing a study. Now, I'm going to also step back to 2011, as I did before when talking about the Precision Medicine Initiative. And Dr. Jain noted these data, but this is from the pivotal trial. This was the first proof in a large population that CFTR modulator therapy works. And you can see improvement in lung function and reduction in exacerbations. But I just wanted to highlight that we are now have approval for ivacaftor in the US for babies older than 4 months of age, which gives us the opportunity to give very early treatment. They have to have one of 38 variants or mutations, but this is still less than 8%, less than 9% of people with CF. And so this is just the list of all the studies that we've done. And as of right now, there's an ongoing trial in babies who are up to 4 months old. Because of the way the liver changes rapidly after birth, the earliest stage is 43 weeks gestation. So you may know that full term is 40 weeks on average. And so a few weeks after birth, kids have been enrolled in this study. And I also want to highlight that ivacaftor has been in the study of 1 to 2 year olds. We saw this big drop in sweat chloride down within the normal range, as well as changes in function of the pancreas. So many of you or your kids may have had their poop tested to see if they have an enzyme called fecal elastase. That's a pancreatic enzyme. It's stable at room temperature. It's not affected by taking pancreatic enzymes. And so at the beginning of this trial, the kids mostly had pancreatic insufficiency, pancreatic function improved. And so many of them had a normal pancreatic function test at the end of the trial, starting this young. And now I'm going to an old drug for most people, but something that is still now approved for younger kids. So Orkambi, we know it's much less efficacious than Trikafta, and we also know that it only works for patients who have 2 copies of the F508del mutation. But in the study of 2 to 5-year-olds, which I was privileged to lead, we saw the same thing, that pancreatic function went up, and a number of kids, so it was 4 out of 35 kids did get pancreatic function back, but there was a washout period before the open label trial. And the pancreatic function quickly gets worse when you go off medicine. So this modulator, although it's not as efficacious, it doesn't give as much of a boost to the CFTR protein, it still has some clinical benefits, and we are currently doing a trial of 1 to 2-year-olds. So what's happening with Trikafta? That's why you all came. So the expansion studies, and Dr. Jain mentioned this, have been completed. We had FDA approval, and that was last June, and there was much celebration. But I want to give you a little bit more background, because we actually did 2 pharmacokinetic studies. One was with this compound elexacaftor added to tezacaftor and ivacaftor. You may recognize that that combination is Symdeko. But there was a backup agent, and these looked fairly equivalent in earlier studies, earlier phase 2 studies. So they hadn't yet decided which one they were going to do in the trial of older kids. Now, many pediatric pulmonologists said that's not ethical. You need to do this once you choose the adult ones. But many parents and researchers like me thought we need to get a head start. These compound combinations look like they're safe. Let's get started on this so that we can get started on the trial as quickly as possible. And so we did. So you remember, Trikafta approval was in 2019, and we started enrolling kids in the extension study already a few months later. So now, we didn't know that when we were planning the study, we would have a pandemic. So we had to pivot. This was a multinational trial that I co-led with Claire Wainwright in Australia. And we had very frequent meetings because we had to make sure that everybody was safe, everybody got their medicine, that we did the best we could with pulmonary function and other monitoring. But a lot of kids were staying home and having blood draws and doing home lung functions. And that's not considered official data for the Food and Drug Administration purposes, but we were able to see it, and we successfully got this. And because of that, the long-term safety study has actually been made longer so that we get more data on file, even after this drug has been approved. And kudos to all of the parents and kids who continue on this study. They could get the drug commercially, but they're still coming as research volunteers. And here are some data from the trial that we published last summer. So I want to point out, this is very important, that the average lung function in this population was about 89% of predicted, so in the normal range. And very few kids, 10 out of 64, had a lung function less than 70%, and 30% were, at their peer normal or slightly below for CF kids and within normal limits. So they started with much higher lung function. Even so, we saw that on drug, there was an increase in lung function that is just as high as in the older people who had lower lung function to start. everybody was thinking like, in normal range, who knows if they'll go up, but they certainly did. Similarly, a big drop in sweat chloride. And then these are just data showing improvement in quality of life surveys, include that decrease in sweat chloride and an improvement in body mass index, and then our approval quite quickly. So many of you want to know about what's going on with the 2 to 5-year-olds. So this study was fully enrolled in December. And so this is a 24-week study. So the last patient, last visit will be sometime in the early summer. And people ask me this all the time. And there was a question that David sent ahead of time. When are we going to know about approval? So I don't know that. And the company, Vertex, who makes it, doesn't know it. But I will point out a little trick of the trade, literally. So Vertex is a publicly traded company. So it's subject to Security and Exchange Commission regulations, the people who oversee stocks and companies that trade stocks. So that means that they have to announce big steps in clinical trials with the Food and Drug Administration and make that public. So you can find out because they have to make it public, but the FDA will have it on a website as well. And they issue what's called a PDUFA date, which is the last day that they can make a decision on approval. And PDUFA is a weird, it's hard to say, but it means Prescription Drug User Fee Act. So companies pay the Food and Drug Administration to review their data. And in exchange for that, the FDA has to say when they're going to make the decision. And you may have heard some of this in the vaccine trials. And you can follow Vertex press releases to see when that date is. Now, I also want to touch on something that's really important to the CF community, and that is that there's variation in modulator eligibility. And this is a table that we published in a paper, version of this in 2021. And it's really important to note that race is a social construct. It does not predict your actual ancestry, and it does not predict at all what genes you have. And yet, CFTR variations have arisen all over the world. And so depending on where your ancestors are from, you are more or less likely to have certain mutations. And so what this means is that while in non-Hispanic white people, and I mentioned this is Trikafta, 88% are eligible, it's much lower in people who are Black, Hispanic, or of other races. And this is important because in the United States, this group that some people used to call minorities are now the rising majority. So our country has always been a great place for people to come from all over the world. And we are seeing a change in the population. We all need to be attentive to that. And so what happens if you're not genetically eligible for modulators? So one of the things that's available to some people who aren't genetically eligible is serotyping. This is truly personalized medicine using your own cells. It's nasal cells taken by a swab in the clinic. It is not terribly comfortable, but it's not worse than a COVID test. And most of us have probably had those by now. So the person's cells are actually tested against these medicines in the Petri dish, and they measure electrical current, and many people have been found to have a modulator that works for them. And even more exciting, insurance companies will also often approve for CF because the modulators are well known and they decrease poor health and hospitalizations and things like that. So if this isn't something that you or your child has heard about and you're not genetically eligible for a modulator, please talk to your care team. And there's a really good track record of finding modulators for people. Of course, it's not everyone. That's very disappointing. So, and I put this picture up. These are Michelle and Terry Wright, who founded the National Organization for African Americans with CF. And Terry was diagnosed when he was 54 years old because the CF was unrecognized. But I put this up here specifically because he's one of many people who is eligible for Trikafta based on this type of testing. So what if you don't have a modulator available even through theratyping? Well, there's a lot going on, and one of the things that is in the planning phases is this is a press release from 2016. Vertex and Moderna established a collaboration to discover and develop mRNA therapeutics for cystic fibrosis. And by now you've all heard of mRNA and of Moderna. And then remember that the CF Foundation is investing a whole lot of money to advance gene therapy. There's been a lot of progress in gene therapy for other diseases, and that nothing is going to stop until we can say cure found. So thank you very much. I'm going to stop sharing and open it up for questions.
Thank you, Dr. McColley and Dr. Jain. We did have quite a few questions that came in regarding pregnancy and everything. And some of the studies, one of the questions, if you're looking in the chats, was having a son with a double rare mutation. How can we help to drive studies and ultimate therapies for the population of these people? Are there opportunities for engagement in studies? I'm sorry, that's actually the wrong question. In reference to the pregnancy data, was there data restricted only to women, or is there data around men having children?
Your microphone is your sound is a little dicey.
So the pregnancy data reflects women. The issue with male infertility is that most CF males have an absence of the vas deferens. And so at this point, we don't think that Trikafta can actually rescue the vas deferens. And so it is not anticipated that it'll have much of an effect on male fertility. And so the data that's reflected in the registry that I showed you is CF women who actually carried a child to term or pregnant delivery.
There's another question around, in reference to the data that was shown, you mentioned on the first slide that COVID might have an impact on the reduction of symptoms and side effects. I'm wondering how much of an impact COVID had on the rest of the positive data that was presented. Do we know?
Well, it's hard, the data I'm showing you is registry data, and the way that data is generated is that each CF care center inputs into this web-based registry what has happened in each center. It doesn't have the granularity to be able to delineate how much is related to Trikafta or COVID. I think we'll have more clarity on the effects of each as time passes and we hopefully get past the pandemic. And if the trends we've seen between 2019 and 2020 are consistent as in each subsequent year, I think we'll be able to say with more confidence that this really is a Trikafta effect and less of a just due to the pandemic.
Thank you. How many CF patients started Trikafta but either had to reduce their original dosage or stop taking Trikafta altogether because they couldn't tolerate?
Well, I'll let Susanna talk about her folks, and I can comment on mine after.
Yeah, so this is still an evolving picture, and we don't really have good data collected on a national basis. It is not unusual in children to have, colds and to have other things. And so the liver in children is more reactive than it is in older people. And so we do have situations both in the clinical trials and in patient care where we pause because we see liver function test results going up showing some liver inflammation. And to be clear, this is something that we've seen in kids with CF for many years before we had modulator therapies. In the clinical trials and in clinical practice, almost always after taking a break, you can safely restart it, often without a dose modification. Sometimes a practitioner will say, let's try the half dose first, or just the morning dose in the case of Trikafta, and then go up and do some liver function testing in the meantime. The side effect profile continues to be emerged. You know, what we look at in the clinical trials are things that we know really affect long-term safety. I know that there have been concerns about anxiety, depression. There have been concerns about acne. There have been concerns about lots of side effects, and we don't really have parameters around that yet. But I would say that it's very unusual to be completely unable to tolerate the medicine, even if the even if the drug has to be paused and restarted. Manu, what do you have to say?
Yeah, no, I echo that. You know, I think that in our experience on the adult side, we've had to pause it. Maybe 10% of our patients, but most of those folks were able to resume Trikafta safely. You know, we've had a couple of people who've had to stop it. And we're not able to resume it, but it's a really low number. I would say it's under 5% that have been unable to continue on Trikafta.
There was a question, can you please provide information on Trikafta studies for populations under 2 years old? Is that underway, or how will individuals be selected?
Yeah, thanks, David. I was actually writing something in the chat box as we were speaking. It wasn't how many there were above it as they go by. But so I want to say something that I didn't talk about with the FDA is that if a drug might benefit children, and all CFTR modulators might, companies are required to put in preliminary plans about how they're going to extend the label. And so this study has not been announced and is not recruiting and is not underway. But what happens is that the company looks at data from the next oldest age group. And then they say, okay, we've got this right, or we've got to make some modifications in it so that the protocol is done just in time and there's an opportunity to start the trials as quickly as possible. And so we really saw that. That was part of what I was talking about with the 6 to 11 label extension, like doing 2 different pharmacokinetic studies so we're ready to go as quickly as possible. And, you know, we all have the same goal. We want the medicines to kids as quickly as possible. And we also want safety. And, you know, as I noted, for different reasons, Vertex is publicly traded. More people get medicine, you know, more money is made. So there's high motivation. And I would also thank the CF community because we have great participation in all of these trials and they move quickly so that we can get there. So I would keep your eye on the CFF website and the clinicaltrials.gov website, and also talk to your care team because little kids are seen frequently. I'm going to make one more note about this, which is that as we get into the very young population, the less than 1, we generally do very small cohorts, like starting with 18 to 24 months and then going down, you know, and when we get below a year, it's in 4-month increments because of developmental changes in drug metabolism and potential toxicity. So that's why we're doing less than 4-month-olds for Kalydeco now, but we are marching along here much more quickly than we did in the 2 to 5 study of ivacaftor.
And we're coming up on our hour, but we have time for maybe 1 or 2 more questions. One in the chat was, is there any data for post-lung transplant patients taking Trikafta? I know there was concern with potential interference with anti-rejection medications.
Yeah, so there is a lung transplant consortium that is funded by the CF Foundation, and they recently reported out their experience. It was not part of a clinical trial. It was just sort of a collective experience of starting it in patients who'd had a transplant, mostly lung. There were some liver transplants in there. And so there is some experience, and the bottom line is that patients who've had a transplant can take Trikafta safely. You may need to readjust your rejection medications. That may need to be something that's done with the transplant pharmacist, but it can be done. Now, the effects, if you've had a lung transplant, will obviously would not be in the lung. We don't expect the transplanted lung to respond, but there may be other effects on your sinus symptoms, your GI symptoms. If you have diabetes, it may improve some of your glycemic control. So there isn't a collective experience in transplant patients, but not of a sort of a clinical trial that we've talked about here for most of our time.
Great. And maybe one of the last ones, for those who stopped treatment, what was their health afterwards? Was there an overall decline of their health, or did the health decrease quickly after they stopped taking Trikafta?
Yeah, I think that there is this concern, and that's why we make every effort to resume it if we have to temporarily halt it for adverse events, such a rash, liver function abnormalities. Our goal is always to resume it as quickly as we can, because there are concerns about the decline in health. Yes.
Excellent. Well, that's just about it at our hour time. So I'd like to thank everybody for joining us today. And I'd especially like to thank Dr. Susanna McColley and Dr. Manu Jain for all the information they shared today. As always, you can always find the best resources and information on the cff.org website, especially around the PROMISE study and some other things that popped up in the chat. And if you have any questions or have suggestions for future town hall subjects and topics, please reach out to me, David Oshinsky, and we'll be happy to consider those in our roster of upcoming CF outreach events. But in the meantime, this meeting was recorded and will be posted to our YouTube channel, and we'll send a reminder out on social media, so anybody that couldn't attend will get to view the information presented here today. So thank you all again, and with that, have a great week and a great weekend coming up. Thank you.
Bye, everybody. Take care.
Thank you so much.
For coming.
Have a great day, guys.